Hello and welcome to Insight Ophthalmology. This is Dr. Amrit welcoming you to another video on Bscan. Today we are studying how to do a Bscan of various ocular tumors. So without any delay, let's get started. Let us start first with the choroidal melanoma. Now before we go into the details of Bscan in choroidal melanoma, let us see some of the important features of choroidal melanoma. Number 1. A melanoma of the choroid is usually solid in consistency. Number 2, its shape is like that of a collar button or it looks like a mushroom shape. The reflectivity of a choroidal melanoma on a Bscan will always be a low reflectivity or it will be a medium internal reflectivity. And I will tell you further why is it so. Sometimes an acoustic quiet zone can be present at the base of the tumor somewhere over here, and that is called acoustic hollowing. And why do we see an acoustic quiet zone at the base? Because what happens is that a melanoma usually is a solid consistency tumor. However, at the base sometimes what happens is there will be necrosis of the inside the melanoma. Now because of the necrosis there will be an empty space which is created and there will be no echoes which will come from that empty space, and therefore that acoustic quiet zone is called the acoustic hollowing. A melanoma, because it's a malignant tumor, it will have internal vascularity, and since I told you in my previous video that internal vascularity is nothing but we ask the patient to look at a point and we keep our probe also stationary. So our probe is stationary and the patient eyeball is also not moving, and at that time if we record certain spontaneous low spikes, it indicates that there is vascularity present inside the tumor. And presence of internal vascularity is actually a feature of malignant lesions. The benign lesions usually do not have their independent blood supply or internal vascularity, right? So a choroidal melanoma always has to be differentiated from its benign counterpart, that is the choroidal nevus. So what happens is that in a choroidal nevus, we do not have any internal vascularity. Now what happens is that as this tumor grows and into a mushroom shaped growth or into a collar button growth, what happens is that at one point it will break the Bruch's membrane and then enter into the vitreous cavity as a projection like this, right? Now as it is growing, it is actually going to separate the retina also and take it along with it, and therefore called a retinal detachment. Now because this is a retinal detachment, there will be fluid collection beneath the retina, and that is called the subretinal fluid. So subretinal fluid is also associated with the choroidal melanoma. Now as the tumor is actually growing, it will cause a process which is called choroidal excavation. So choroidal excavation is nothing but normally we have the normal choroid over here, but as the tumor grows from the choroid, it has a tendency to grow in all the directions. So as it grows even towards the choroid, a part of the choroid will be actually occupied by the tumor, and it will look as if there's an indentation or an excavation or a pit in the choroid, which is called choroidal excavation. Now let me tell you why in a case of choroidal melanoma we have low to medium dense echoes, right? So as I told you in my previous video what I meant by low and medium dense echoes. So in a case of choroidal melanoma, a choroidal melanoma usually is a collection of the malignant cells, and these malignant cells are very tightly packed, right? So what I mean to say is that the consistency of a choroidal melanoma is solid consistency, and moreover it is a very dense structure, right? Now as the structure becomes more and more dense, what happens is that it tends to absorb the sound waves and convert them into heat energy, right? So this process of absorbing the sound waves and converting it into another form of energy, that is the heat energy in this case, is called attenuation or absorption, right? This is also something that I explained in my video on the basics of Bscan. So this process of attenuation occurs in a case of the choroidal melanoma, and therefore what happens is that because the melanoma cells, which are very densely packed, they are absorbing most of the sound waves, they are actually not reflecting much of the sound waves back. And I told you what is meant by the echoes is that echoes are nothing but they are the reflected sound waves, right? Now since absorption diffusion is more than the reflection. Therefore, the echoes that we are getting in case of the choroidal melanoma will usually be very low echoes or medium dense echoes, right? However, in the beginning, as the sound waves are going to strike the surface of the melanoma, we are going to get a very tall spike, and later on the spikes are going to reduce. Now let us see that why do we get that tall spike. Okay, now in this picture over here, if you can see, here what is happening is that we are seeing tall and almost very tall dense echoes, right? So why is that? But this is also a case of melanoma. Now what did I tell you? Whenever the structure of melanoma or any structure is very dense with similar looking cells, the sound will travel through it and most of it will get absorbed, and a process will occur which is called attenuation, and therefore we will get low dense echoes. However, in the same melanoma, if there is necrosis in some part, or if there is cystic changes in some part, so what happens is that this homogeneous structure is being converted into a heterogeneous structure with variable density, right? So now the density of the structure will also change, and within the internal density is changing, the internal consistency is changing, and whenever the internal consistency changes, we are going to get different types of spikes, and usually we get very tall spikes, right? So what I want you to remember is that when this is dense structure, we get low dense echoes because of the low internal echoes, and whenever the consistency varies because of necrosis and because of the cystic changes, right? So even a low dense melanoma can actually look like very high dense, can give high dense echoes. Now have a look at this two fundus pictures. One is a nevus, okay, which looks like a flat lesion, and the other one is a melanoma, which is a collar button or a mushroom shape appearance, right? So let us differentiate these two and understand the concept of density and understand the concept of echoes in these two, okay, on the Bscan. Now for a melanoma, for a nevus, I will tell you what is a nevus. So nevus is actually a benign structure, so it will actually be consisting of the normal choroid. Okay, so we will have a normal choroid in place. Along with that, we will have certain melanocytes, okay, present here. So you have different two types of cells, basically a normal native cellular architecture of the choroid, and on top of that we have certain benign cells. So there is an inconsistency present in the nevus. However, when we talk about melanoma is actually a malignant growth. So in the malignant growth, all the cells are going to be malignant. The normal choroidal tissue is being replaced by all these dense growth of these melanocytes which are malignant in nature, right? So it's a very dense structure when it comes to melanoma and not so dense in case of a nevus. Therefore, when we talk about nevus, because the structures are not dense and they have different kind of variability, the sound is going to get reflected within the structure because of different densities within the nevus itself, and we are going to get tall spikes. However, in case of a melanoma, we're usually going to get low spikes, or we're going to get medium dense spikes because the density of the tissue is same and it is more dense and there is attenuation which is occurring, right? Now let me tell you why do we get a tall spike. So if this is a melanoma and this is our vitreous cavity, so this is the eyeball, cornea, right? So when the sound is going to travel, it is traveling first the spikes are coming from the cornea and from the lens, and then the vitreous, in the vitreous we do not get any spikes. Now when the sound waves are going to reach the surface of the melanoma, what happens is that there is a sudden change in the density between the vitreous and the melanoma, and because whenever there's a change in the densities of two structure, we will get an echo, right? So the first echo that we get, because of the sudden drastic change between the density of the vitreous and the surface of the melanoma, we are going to get this tall spike over here. However, as the sound is going to enter inside the melanoma, the structure now is not going to change much, and therefore it's all dense. It is a very dense structure and a lot of it is going to get absorbed. The sound energy is going to get absorbed. Therefore, we are going to see this attenuation. That is, the spikes are going to now reduce, right? So if you're going to draw a line from the base, from the top of this peak, okay, and you are going to trace it to this downwards dropping low spikes, we are going to actually find an angle of attenuation, and that angle of attenuation is called angle kappa. Right, so this is called angle kappa. Now greater is the angle kappa, greater is the attenuating capacity of the medium. Right, so about angle kappa I have explained it to you in the video on the basics of Bscan. So if you want, you can visit that video again and clarify your concepts. So melanoma and angle kappa are related, attenuation is related to melanoma, low spikes are related to melanoma, acoustic hollowness is related to melanoma. However, in a nevus we are going to see tall spikes. Now this picture over here actually depicts the acoustic hollowness which occurs because of the necrosis at the base of the melanoma. So you can see that this is the mushroom shaped growth which is occurring, and you can see that here there is a eco-free zone which looking black in color, which is the zone of acoustic hollowness because of necrosis at the base of the tumor. Now at the same time, if you trace the choroid actually it should have continued like this. However, you can see this excavation in the choroid, and this has occurred because of the mass effect of the melanoma. Similarly, this picture over here shows the fundus picture of a lesion, okay, and then we are seeing on the Bscan a mushroom shaped growth with decreased density at the base, choroidal excavation, and on the A-scan overlay we can see a tall spike, and the spikes are then gradually decreasing into very low dense echoes, and therefore there's an angle kappa or there is an attenuation. So all these features suggest that we are dealing with a case of choroidal melanoma. Now this picture over here shows us a choroidal nevus. Okay, so we can see that a choroidal nevus also can be a dome shaped structure, or it could be irregular in shape. However, the structure will not be as dome shaped as a choroidal melanoma. So these are usually shallow lesions, okay, and the reflectivity is usually very high, and the reason I told you, because the density is different within the structure of a nevus, because it is actually having choroid, normal choroid, and in that we have the melanocytes. However, in case of a melanoma, the entire choroid is actually replaced by densely packed malignant melanocytes. Now also in case of nevus, if you do a stationary echography in which you don't move the probe and don't let the patient move the eyeball, you will see certain spontaneous spikes in case of melanoma, indicating that there is internal vascularity. So internal vascularity is a feature of malignant lesions, and since nevus is a benign lesion, we will have no vascularity in a choroidal nevus. Now let us talk about one more melanocytic tumor which is present specifically on the surface of the disc, okay, and that is called the melanocytoma. So melanocytoma also, since it's benign, you're going to have certain normal disc structures, you're going to have attachment of vitreous, and then you also have the melanocytes which are present in that. Because of that variability, we are going to see high reflective lesion present centered on the disc, and it is also going to show some amount of back shadowing. Now let us talk about another lesion, the choroidal hemangioma, which is a very close differential of the choroidal melanoma. So a choroidal hemangioma also can be dome shaped. However, we do see diffuse type of choroidal hemangiomas also, specifically in case of the Sturge-Weber's syndrome, right? So in Sturge-Weber syndrome, we are going to see a diffusely spreading hemangioma rather than a localized hemangioma. Now, one more differentiation with melanoma is with respect to the location. A melanoma can occur in the anterior part of the choroid, in the posterior part of the choroid, or near the equator, anywhere, right? And it can also spread anteriorly to the ciliary body. However, in case of hemangioma, usually the location is a posterior location. Now, another thing about choroidal hemangioma is that the consistency is uniform throughout, because a hemangioma is nothing but it is a collection of the channels which have this septae, which is separated by various kind of septae, and in that we have the blood which is trapped, right? So they're nothing but dilated blood vessel collections, okay? So that is the hemangioma histology, if you think about. So we are actually having these cystic like spaces, we can call them cyst like spaces, and they're separated by the septae, which is not common in case of the melanoma. So since you have different types of structures present, specifically the septae, the columns of blood, and a little amount of blood which is flowing through it at a very low very low flow pressure, right? So we have variable kind of densities, although it looks very regular on a Bscan. So therefore the reflectivity in case of hemangioma also will be a high spiked reflectivity. Okay, so we are going to get this high echoes in case of hemangioma also, just like the nevus. So this picture over here shows on the fundus image, you can see here an orangish kind of lesion, which they suspected to be a hemangioma, and then finally they did a Bscan. You can see this lesion over here, which looks almost homogeneous with certain difference in changes here, inconsistency here, and then on the Bscan it showed that there is a tall spike, and followed by that there are high reflective spikes. There is no angle kappa, and therefore you have to think in terms of hemangioma. Now if there was an orange pigmentation or something drusen, things like that present, then you would think in terms of the choroidal nevus. However, since the pigmentation over here is totally different and you are seeing a reddish orangish lesion, it goes more in favor of hemangioma. Now let us talk about another type of lesion, which is another differential, and that is the choroidal metastasis. Now the choroidal metastasis, unlike the melanoma, will be very irregular in shape, and they will be lobulated also. They will be shallow lesions, and usually they are associated with exudative retinal detachment. The structure could be solid or it could be a variable consistency, so that is very important. Okay, now the reflectivity that we see, we are going to see high to moderate reflectivity. And why is it that so? It is because we are having a normal choroid, and on top of that a tumor from somewhere other part of the body is coming and getting stuck through to the normal choroid. So we have in that location, we have the normal choroid, we have the tumor cells from somewhere else, and then we have certain other growths, and because of that, because of the variability, we are actually seeing high to medium reflectivity in case of choroidal metastasis also. Now, choroidal metastasis can again be unilateral or it could be bilateral. So that also you have to think. So if you want to remember something about choroidal metastasis, think about bilateral presentation, think about a shallow lesion, think about high reflectivity, and specifically ask the history. There will be a history of lung cancer, or there will be a history of breast cancer. Okay, so usually in women, breast cancer is the leading cause of choroidal metastasis, and in men it is usually the lung cancer which can metastasize to the choroid. Now, another kind of lesion which present as this whitish plaque lesion in the posterior pole is the choroidal osteoma. Choroidal osteoma is nothing but it's a benign tumor of the bone, okay, or sorry, it has a tumor which has the bony elements. So as I told you, bone is the densest structure that you can think of, and therefore the attenuation by the bone is maximum. So you can see that this bone-like structure which is coming from this plaque is absorbing most of these sound waves, okay, causing maximum attenuation, and therefore you are seeing this shadows over here. Okay, and this represents actually the presence of calcium, because bone has calcium, and if you correlate these two fundus picture, you can come to a diagnosis of choroidal osteoma. Now let us talk about another tumor which is very common in children, and that is the retinoblastoma. Now the morphologically retinoblastoma could be focal, it could be multifocal, but what is important is the presence of calcium deposits in the retinoblastoma. Now, because of the calcium deposit and because of the ability of calcium to absorb most of the sound waves, it is going to cause this acoustic shadowing behind, right? Now, the shape of retinoblastoma could be variable, and there will be a retinal detachment, because as the tumor is going to grow, it is going to take the retina along with it, causing an RD, and below the RD there will be collection of the subretinal fluid. Now, because the retinoblastoma has calcium, there will be high reflectivity, okay, and it could be unilateral or bilateral. An important thing is that in retinoblastoma, usually the axial length of the eyeball will be normal, right? And why am I telling you that is because this point helps us to differentiate it from its other differential diagnosis. Now over here you can see this Bscan image, and you can see here the presence of these very whitish lesions on the Bscan with an after shadowing indicates that there is presence of calcium in this lesion, and on the A scan overlay also we can see high spikes corresponding to the calcium deposits in the retinoblastoma. Similarly, this picture over here, you can see this big calcium deposit with an after shadowing and a high spike suggestive of retinoblastoma. Similarly, here we can see this collection and you can see the high spikes. Now, there are a lot of differentials of retinoblastoma, but the major ones are the persistent hyperplastic primary vitreous or the retinopathy of prematurity, and then we have the Coats disease. In persistent hyperplastic primary vitreous, we have the persistence of the primary vitreous, which usually extends from the back of the lens to the retina, and it is traveling in the vitreous cavity. Similarly, in retinopathy of prematurity also, we might see a closed funnel RD as a sequelae of ROP with some calcium deposits, right? So they might mimic a retinoblastoma. However, the difference is that in a retinoblastoma, always the axial length is normal, whereas ROP and PHPV, the axial length will usually be smaller for the age of the patient, right? Now, coming to Coats disease also present with can mimic a white reflex. However, to be more specific, it is more of a yellow reflex because of the deposition of the cholesterol crystals and not the calcium crystals. However, Coats disease will be unilateral, and retinoblastoma usually is bilateral. There will be a family history in case of retinoblastoma, whereas there is no family history in case of Coats disease, and there will be calcium deposits in case of retinoblastoma, whereas in Coats disease it is the cholesterol deposits, and therefore they are not as reflective as the calcium. So this table over here shows us the various conditions which can be associated with intraocular calcification. So what I want you to remember is retinoblastoma, and then there is astrocytic hematoma also, which is a tumor present on the optic disc itself. And in this tumor also we will have this eggshell-like calcifications, okay, multiple calcium deposits. Then we have chronic retinal detachment, which can show calcification. Cystosarcosis also can show calcified cystosarcus. After they died, after the larvae is going to die, they get calcified. And then in the choroidal lesion we have osteoma, which I showed you, and there are other lesions also like the phthisis bulbi.